Today, we are diving deep into one of the heart's most important but sometimes problematic pieces of machinery. We're talking about mitral regurgitation. What happens when a critical one-way door inside the heart suddenly starts leaking backward? Understanding this is absolutely essential to protecting the entire cardiac engine.
So this is really the core question we're going to tackle. It seems like a simple plumbing problem, right? A leaky valve. But it has these profound, cascading consequences for how the heart functions. We're going to break down exactly what that means, how you can spot it, and probably most importantly, when it's time to step in and fix it.
But look, before we can even talk about the leak, we first have to appreciate the really elegant mechanics of a valve that's working just the way it's supposed to. So let's take a look at the normal sequence of events.
Honestly, this is just a beautiful piece of biological engineering. It's all about perfect synchronization. So as the ventricle gets ready to pump blood out to the body, these things called papillary muscles actually contract first, kind of preemptively pulling the valve leaflets into position. Then, as the pressure inside the ventricle just skyrockets, it slams those leaflets shut, creating this amazing keystone effect where they lock together perfectly. The chordae malade and the annulus, think of them as the final failsafes, like tethers, making sure that door stays sealed tight. It's a perfect one-way system.
Okay, so what happens when this perfect system breaks down? Well, this is where regurgitation, that backward flow of blood, starts to happen.
And here is the core problem in a nutshell. Normally, 100% of the blood in the left ventricle gets shot forward into the aorta to feed your whole body. But with mitral regurgitation, that faulty valve means that with every single heartbeat, a portion of that blood is forced the wrong way, backward into the left atrium. It's literally fighting against the normal flow of traffic.
And the leak isn't usually caused by just one single thing. Any part of that elegant system we just talked about can be a point of failure. The papillary muscles can get pulled apart if the ventricle gets too big. The chordae, those tethers, they can stretch or shorten or even snap. The leaflets themselves can get all floppy and redundant. And even the annulus, the ring that the valve sits in, can stretch out or get calcified, which completely ruins the seal. So this brings us to a really crucial distinction. We have to figure out why the valve is leaking. Is the problem with the valve itself, the leaflets or the cords? We call that primary MR. Or is the valve structurally okay, but it's being pulled apart by a sick, dilated ventricle? That's secondary MR. And trust me, this distinction is absolutely fundamental because it dictates the entire game plan for management.
So how does this mechanical problem actually present in a patient? Well, some people can be walking around with this for years and feel totally fine. But eventually, that back pressure causes symptoms like fatigue and shortness of breath. But for a clinician, there's one classic physical exam finding we are trained to listen for.
It's a sign that you can only pick up with a stethoscope, a very specific sound that tells you that valve is failing to close properly.
It's called a pansystolic murmur. Okay, let's break that down. Pan just means all, and systole is the squeeze of the heart. So it's a whooshing sound that lasts through the entire squeeze. We hear it best at the apex or the bottom tip of the heart, and it classically radiates out towards the armpit or the axilla. In more severe cases, you might also hear this extra thud, an S3 sound, as that huge volume of backed up blood comes sloshing back into the ventricle.
So beyond the stethoscope, our initial tests start to confirm what we suspect. An ECG might show evidence that the left atrium is strained or the left ventricle is getting too thick from all the extra work. Sometimes you'll even see atrial fibrillation. And a chest X-ray will often flat out show that both the left atrium and the left ventricle are enlarged. They're all just pieces of the puzzle pointing in the same direction.
But to really, truly understand what's going on, to see the leak with our own eyes, we need to see the valve in action. And for that, the definitive tool is the echocardiogram.
An echo is just invaluable. It's a total game changer because it doesn't just confirm the leak, it tells us the whole story. It shows us the precise problem. Is it a flail leaflet? Is it prolapse? And it quantifies the damage, measuring the chamber sizes, the heart's function, even the pressures in the lungs. This is the roadmap that guides every single treatment decision from here on out. So now we've got the diagnosis, we know the cause, we've seen it on the echo. The next, and maybe the most critical question of all, is when do we intervene?
This really is the key decision point. If you wait too long, irreversible damage can happen to the heart. But if you intervene too early, you're putting the patient through the risks of a major procedure unnecessarily. So how do we know when the time is just right?
Well, the guidelines give us some really clear triggers. The most obvious one is when a patient starts developing symptoms like getting short of breath.
But, and this is so important, we also act before symptoms if we see objective evidence of trouble. A weakening ventricle, rising pressures in the lungs, or a new heart rhythm like atrial fibrillation. The whole goal is to fix the valve before the heart starts to fail.
And to catch that dysfunction before it becomes permanent, we are laser-focused on two critical numbers that we get from that echocardiogram. Okay, the first one is an ejection fraction, or EF, less than 60%. Now you might be thinking, wait, is it an EF of 55% still in the normal range? Well, yes, but not in severe MR. The leaky valve actually creates an easy escape route for the blood, which artificially inflates the EF. So when that number drops below 60%, it's a huge red flag that the heart muscle itself is already starting to fail.
The second number is the left ventricular end systolic dimension. Basically, that's just a measurement of how wide the ventricle is at the end of a squeeze. If it grows beyond 4.0 centimeters, it's a clear sign that the chamber is dilating. It's getting stretched out and losing its shape. And that's a change that can become permanent if we don't act fast.
So once that decision to intervene is made, the good news is we have a whole expanding toolkit. The gold standard for a long time has been surgical repair or replacement. But today, we have less invasive options like transcatheter repair with devices like the MitraClip. And for some folks, especially with that secondary MR, just optimizing their medications or using a special kind of pacemaker can make a world of difference.
And this quote really captures the modern philosophy. The evidence is just crystal clear. For a lot of patients, especially those where the valve is highly repairable, stepping in early, sometimes even before those hard numbers are hit, leads to much better long-term survival and a better quality of life. Which leaves us with this final thought. As all of our treatments, both surgical and these newer transcatheter therapies, get even safer and more effective, the entire paradigm might shift. The conversation may no longer be about waiting for just the right moment to intervene, but instead about finding the earliest possible moment to restore the heart's normal function. It's a fascinating thing to think about.